especially. I want to see some girls. Come. यहाँ इतनी कम है इस क्लास में वैसे ही चल रहा है ना. So ये ऑन है रिकॉर्डिंग. Thank you. Yeah. So, can you tell me from previous pharmacology class as well as from physiology class, first or two rows, please. Excuse me, come back. ये मैं रिजर्व करके रखा स्पेशली आप लोग के लिए. हाँ, गर्ल्स इन द फर्स्ट रो. वेरी नाइस. आज आई गेट टू सी कि कुछ गर्ल्स भी हैं इस क्लास में. अच्छा, अब भर गया तो थर्ड रो. उससे पीछे नहीं जाना जब तक वो भरता नहीं है. चला गया. anyway, अब जो मर्जी करो. Anyway, so how do you think the effect of these neuromuscular blockers can be reversed? This is from what has already been covered in ANS pharmacology as well as in physiology. अच्छा होगा या if you do something else with your bag. हाँ, कैसे रिवर्स कर सकते हैं? और ये तो खैर कल भी डिस्कस हुआ है in a way. Exactly. So we could use an anticholinesterase inhibitor. And why neostigmine? Why not pyridostigmine? Why not physostigmine? Neostigmine, edrophonium are the most commonly used acetylcholinesterases to reverse the effect of a. And which neuromuscular blocker can be reversed with these? It's only the competitive ones. Okay, so why not physostigmine? Yes, physostigmine would have CNS effect. And why would it have CNS effect? And why not? Why doesn't neostigmine have CNS effects? यहाँ boys को भी मौका देते हैं ना. हाँ. Yes, very good. And why does it cross blood-brain barrier? Very good. And why is it lipid soluble? वाइवा में भी ना आप इतनी मेहनत करवाओगे अगर एक्सटर्नल एग्जामिनर्स या किसी भी एग्जामिनर से तो मार्क्स भी उसके अकॉर्डिंग ही मिलेंगे. खुद से बता दो अगर आता है तो. It is non-polar. And what does non-polar mean? So it's which drug are we talking about? Physostigmine. Yes, okay. It is non-polar, means it is lipid soluble. है ना? So, and why, but yeah, the question was why is it lipid? अच्छा, it is lipid soluble because it is non-polar. और कोई? It is a tertiary amine as compared to pyridostigmine which is a quaternary amine, neostigmine which is a quaternary amine. So, अब दोनों quaternary amines है तो pyridostigmine क्यों नहीं? What is the duration of action of pyridostigmine? Is it longer than neostigmine? Shorter. It has a longer duration of action. So usually you don't need a long duration of action because you don't expect the neuromuscular blockers to have a long duration of action. So you usually use neostigmine or even a shorter drug, that is the shortest acetylcholinesterase inhibitor is edrophonium. Okay, so we use one of those. Now, many times besides these anticholinesterase inhibitors, we also give atropine. Why do you think we give atropine? To reverse or to antagonize the muscarinic effects. Because what are the anticholinesterases going to do and how do they reverse the block is by inhibiting metabolism of acetylcholine. So there is more acetylcholine and it is a competitive block. So which means if there is more acetylcholine, it can block or it can reverse the block by the neuromuscular blockers, which are the competitive blockers. Can anybody name one competitive neuromuscular blocker at this stage? हाँ, यहाँ कुछ नहीं है slide में. Can anybody name a competitive neuromuscular blocker? Excellent, tubocurarine, though we don't use it, but it is the prototype of a competitive neuromuscular blocker. So, acetylcholine, but acetylcholine is not specific for nicotinic receptors. Okay, acetylcholine is not specific for nicotinic receptors. So, which all receptors does it act on? And you gentlemen, please mind coming and sitting in the first row and starting from the first bench, and you also please come here. This is not a movie theater कि आप कोई भी seat पीछे की ढूंढ के बैठ जाएंगे. I said start from the first seat. Okay, so now you shift here. Yes, so it can act at muscarinic receptors also, and we don't want that to happen, and that's why we give atropine along with it. Now, there is another reversal agent called sugammadex, which is specially useful for binding rocuronium and to some extent also vecuronium. But this itself has, so this is basically a cyclodextrin which binds these drugs, but this itself you have to be careful while using because it has caused hypersensitivity reactions, it has caused bradycardia as well as coagulopathy. So, but this is a newer reversal agent that is now become available. Okay, so and I won't waste too much time on that. Then another important thing when you are using neuromuscular blockers are their interactions either with the drug, another drug, or with the disease or with the patient condition itself. So, which could be now coming to the drug interactions. Use of an general anesthetic in combination with a neuromuscular blocker. As I said, that is, what is that called? Using several drugs to produce general anesthesia instead of one drug, balance anesthesia. So, neuromuscular blockers are often used along with general anesthesia when we are using them for surgery, okay, including orthopedic surgery. But what we should remember is when we are using them with general anesthesia, the dose of not only the general anesthetic, but sometimes the dose of the neuromuscular blockers would be less than what we would use without general anesthesia. Where would we use them without general anesthesia? Suppose we are just doing, or we are giving them for ECT or we are giving them for convulsions, there we are using them without general anesthesia. So, the dose there would be more than the dose which is used with general anesthesia, because general anesthesia may itself potentiate neuromuscular block. Okay, and why would that happen? That would be because general anesthetics themselves would decrease motor function by central, first of all by central depression. So, you have the cerebrospinal pathway coming all the way to the muscle, so that itself is going to be reduced, the sensitivity of the neuromuscular junction may be reduced, and also because most of the general anesthetics cause some amount of vasodilation, and it might make it easier for the neuromuscular blockers to reach the neuromuscular junction. And these are the proposed mechanisms why general anesthetics increase the effect of neuromuscular blockers, and which has to be kept in mind. Which are the other drugs do you know of from physiology or from whatever pharmacology that you have read which may interact? So, which means any drug that increases or decreases neuromuscular activity. Chemotherapy is not over for you now, so probably that is why you do not know. So, the other very important drugs that can interact are some antibiotics or antimicrobials like aminoglycosides, tetracyclines, even fluoroquinolones like ciprofloxacin. They can themselves depress the neuromuscular junction. Aminoglycoside, one classic toxicity you will be learning is neurotoxicity, and this neurotoxicity is nothing but a neuromuscular block. Okay, similarly, tetracyclines and as I said, fluoroquinolones can themselves cause a neuromuscular block, and this block is mostly because of inhibition of the prejunctional calcium channels, which reduces the release of the neurotransmitter, that is acetylcholine at the neuromuscular junction. So, there is reduced activity at the neuromuscular junction. okay, which can, so if the neuromuscular junction is already depressed, which means you would again require smaller doses. If you have to use a competitive blocker, you use a smaller dose of the competitive blocker. Okay. Then similarly, calcium channel blockers, local anesthetics, they have been shown to reduce, the neuromuscular, activity and potentiate the effects of both competitive as well as the non-competitive neuromuscular blockers. Calcium channel blockers, both, if they are blocking pre-junctional, then they would be acting at the like the antimicrobials, but they would also block the post-junctional calcium channels, okay, which would in any case decrease muscle contractility, because we need calcium for muscle contractility, and that's why they would decrease effect of both competitive as well as the non-competitive drugs. Okay. Similarly, local anesthetics. Now, how do the local anesthetics act? Pharmacology में अभी शायद नहीं हुआ है local anesthetics? हो गया? हाँ? Yes, very good. So, local anesthetics act by sodium channel block. Okay, and we have seen yesterday what is the main ion that is going inside through the nicotinic NM receptor is again the sodium electrolyte. So, there is a depression of the sodium channels, there is decrease action potential, therefore, local anesthetics again can increase the effect of both the competitive as well as the non-competitive blockers. So, which means it is not that any of these things cannot be used together. So, as I said, obviously we use general anesthetics with neuromuscular blockers. We may have to use, if possible, we would avoid these particular antimicrobials in a patient who is getting a neuromuscular blocker. But if that is also not possible, we just have to keep that in mind, use lower doses of the neuromuscular blocker in such patients. Similarly, local anesthetic, if it has to be used, it has to be used. Okay, then you would use reduced doses. And finally, anticholinesterases, which we have already discussed, they would reverse the block. The drugs that we have studied, just seen the drug interactions till now are potentiating, the neuromuscular blockade, but anticholinesterases are naturally opposing it or reversing it. Okay. Then, as I said, there can be effect of disease or the certain characteristics of the patient. Okay, and disease, obviously, the most important disease that could have an effect on the effect of neuromuscular blockers would be myasthenia gravis, which there is already. What is the problem in myasthenia gravis? Can you remove that bag from in front of you? Can you remove this bag in front of you? Yes. So, what's the problem in myasthenia gravis? Acetylcholine cannot? It cannot activate the receptor. And why is that? What happens to and which receptor does it want to activate? Which receptors? Which receptors are we talking about? All this while we are talking about neuromuscular blockers. So, where are the neuromuscular blockers? Which receptor are they targeting? Which part of the anatomy are the neuromuscular blockers blocking? Okay, which muscle are they blocking? What muscle are we talking about? Very good, skeletal muscle. So, which part of the skeletal muscle? Neuromuscular blocker. So, what do they block at a skeletal muscle? Okay, at the postsynaptic junction of a neuromuscular junction, you mean, right? So, which is the receptor there? Huh? Okay, that receptor is a ligand gated channel, very correct. But which is the receptor? Yes, it is, the sodium is the electrolyte, but what is the receptor? Anybody can help her? No, help her means you can answer to me and that will be a help to her. Yes, you telling her and she saying is not a use. Ab jaw. Okay, so it is the nicotinic? Yes, and NN or NM? NM, yes, absolutely correct. So that is the receptor. And yeah, what was my first question? Yeah, so what happens in myasthenia gravis? So why is acetylcholine not able to act at NM receptor? Ma'am, I am still asking you, yes. So while acetylcholine not able to act at NM receptor? Yes, there are antibodies against the NM receptor, okay, which either destroy the receptor or which are, binding to the receptor, so acetylcholine cannot act there. So there is already this problem at the NMJ junction. So obviously these patients are going to be more sensitive or less sensitive to neuromuscular blockers. They will be more sensitive, and which again doesn't mean that you can't use them, but if you do use them in these patients, you have to be very careful. You have to probably use very small doses. Similarly, age, both the children, especially preterms or infants, as well as the elderly may be more sensitive to neuromuscular block. Okay, and one reason, especially in elderly, would be because of reduced both liver metabolism. Actually, more than the liver metabolism, it's the liver blood flow that decreases, but that in turn can decrease metabolism of drugs, as well as there is reduced renal function. Okay, so that could reduce the elimination of these drugs and hence increase the effect. So elderly, you have to be again be careful, use maybe smaller doses. Similarly, infants or preterms, the neuromuscular junctions themselves may be poorly developed, plus elimination pathways may be poorly developed. You have to be careful, but as the child grows, there can be variable, effects of these drugs. Then what happens in severe trauma or chronic neuromuscular disease? And this is something we have discussed in adverse effects of succinylcholine. What happens in burns or trauma to the muscle, skeletal muscle, or some neuromuscular disease? Okay, what happens which leads to a particular adverse effect of succinylcholine? Anybody remembers from yesterday morning? Nobody? Krish कहाँ है आज? नहीं है? हाँ क्रिश बताओ. मैं वहाँ I got distracted by that bottle being passed around. I hope it's water. हाँ क्रिश बताओ. क्या क्वेश्चन था? मैं क्वेश्चन भूल गई. हाँ, succinylcholine, a particular adverse effect in patients of burns, trauma, bed jaw, or chronic neuromuscular disease. So there are actually, nicotinic NM receptors are not there only at the neuromuscular junction. They are there pre-junctionally, that we've discussed. They may be there around the neuromuscular junction, what are called extra-junctional nicotinic receptors, and which tend to proliferate in a patient of burns, in a patient of chronic trauma, okay, or a patient with neuromuscular disorders. So now in such a patient, what would happen if you give succinylcholine? There is more risk of hyperkalemia, because when succinylcholine before blocking the muscles is going to stimulate, it's a depolarizing blocker. It's going to stimulate the muscle. So as we discussed yesterday, there can be fasciculations in the beginning. So during this stimulation, there can be increased muscle contraction, which can lead to increased potassium, exit from the muscles into hyperkalemia. That you have to keep that in mind. In such patients, also in patients who already have some electrolyte imbalance, patients who have arrhythmias or heart failure, where these electrolyte imbalances could be a problem. What would be the effect of competitive blockers in these patients? Or we should say, what would be the effect on competitive blockers of these conditions? So burns, trauma, etc., succinylcholine, danger of hyperkalemia. competitive blockers, remember there are extrajunctional nicotinic receptors. There are more nicotinic receptors, maybe not just in the NMJ, they are surrounding it. But how would they affect competitive blocker action? Any guess? So do you think competitive blocker action would also be increased, or do you think it may be reduced and we might need higher doses in such patients? Yes, we need higher doses, because even if those are not coming into play at the neuromuscular junction, but they are going to, the competitive blockers are going to go and bind to them. So these patients in fact some may need higher doses. So it's just the opposite effect. Okay, and so severe hypertension, severe dehydration, electrolyte imbalance. So as I've already mentioned, for succinylcholine, you have to remember that it can cause hyperkalemia. So if there is already hyperkalemia, you have to be careful. For the competitive blockers, now you have to remember that electrolyte imbalances can affect neuromuscular transmission itself. Hypokalemia, hypocalcemia से क्या होगा? Neuromuscular junction or muscle contractility, sensitivity increase होगी या decrease होगी? It will be very good, decreased. Okay, so you might have to use smaller doses in such instances. So basically you have to be careful about using these drugs in patients who already have electrolyte imbalances. Okay, so with that I think we finish the neuromuscular junction, and now we move on to the spasmolytics, or what we also call the centrally acting muscle relaxants, but spasmolytics may be a preferred term because as we will see, two of them are not centrally acting. Now these include, okay, so before we come to the drugs, or whether I have missed that slide, I don't know. So what is spasticity, first of all? Physiology. What is spasticity? And if you can guess, the next question would be, what is the difference between spasticity and rigidity? Yes, so which means you know what both are. Okay, so who will try to explain? So what is spasticity and what is rigidity? This is physiology, this is not pharmacology. तो वहाँ spasticity की definition तो है, but क्या है actually, and how would you differentiate between the two? So as you can see, we define it as increased tonic stretch and increased basal tone with muscle weakness. Tone ज़्यादा है लेकिन muscle weak है. And so how do we differentiate it with rigidity? Anybody wants to attempt? Krish, yes.
When it comes to rigidity, so there are three types. There's a dead pipe, cog wheel. There is a dead pipe, cog wheel.
Yes.
And it's a dead pipe rigidity with extra force. And spasticity is just like spasticity ironing movements. Like rigidity cogs behind that. There's basically spasm. That's the difference.
I got you were telling about rigidity, but I did not get the difference between, and so what is spasticity? You were talking about cogwheels rigidity, and what about spasticity? What is spasticity?
There is no external
There is no external
resistance.
There is no external resistance.
Rigidity में हम जैसे एग्जाम्पल करते हैं रेजिस्टेंस लगाते हैं पर spasticity में कुछ और
Anybody would want to differ with Krish? The example you gave of rigidity is absolutely correct, and cogwheel rigidity is seen in Parkinson's. Okay, but spasticity, cogwheel or pinwheel, spasticity की definition के साथ I would differ with him, not the definition, the description that he gave. कोई और? Physiology? So Parkinson's or any condition where there is rigidity, yeah, let's take Parkinson's. Is there an abnormal posture at rest? जैसे आप इसमें देख रहे हो, ये spasticity abnormal posture है, ऐसे है. Parkinson's में ऐसे होता है? नहीं, क्यों? And that is one of the differences, important difference. That is because of a difference in spasticity and rigidity. ये मैं नहीं, actually आप लोग मुझे समझा रहे होने चाहिए थे. क्यों? No, it need not be whole body in either situations. Yes. Though spasticity is more likely to be asymmetric and rigidity is more likely to be symmetric, but it need not be entire body. But there is in rigidity, so around a particular joint, both the flexors as well as the extensors are affected. While in spasticity, it's one, either the flexors or the extensors. Here, what do you think is in spasm? It's the extensor or the flexor. It's flexed. So, and that is why there is an abnormal posture, one. Second, during movement, okay, and if there is fast movement, more resistance is there in rigidity or spasticity? Though in fact, I need not, that's not pharmacologically so much relevant. I need not go into all the differences. But anyway, चलो ये वाला question पूछ लिया तो बताओ. In spasticity, yes, if you try to move it faster, there is more resistance. Anyway, so what is important is that you do recognize that they are two important conditions. Why it's important? Because the treatments are also different. So, the drugs that we are discussing now are usually not effective in Parkinson's. They are effective in other causes of, and they are effective in spasticity. Rigidity is anyway a component of Parkinson's, not spasticity. So, with that, let's now move on only to spasticity. I am not discussing rigidity now. So, what can be the causes of spasticity? I am sure you know that. It could be, spinal cord injury. It could be, central cause. It could be neurodegenerative diseases like you heard of multiple sclerosis, okay, or ALS. You know what is ALS? अच्छा वहाँ लिखा ही हुआ है amyotrophic lateral sclerosis, which is a kind of, what kind of a disease this is? I'm sure you've heard of that in physiology. It's a kind of a motor neuron disease. Okay, so there is degeneration of motor neurons, so there is a gradual, loss of movement, but there might be associated spasticity. Okay, and cerebral palsy is the developmental, problem. And of course, stroke, or there could be traumatic brain injury. So, there could be traumatic spinal cord injury, there could be traumatic brain injury, there could be multiple sclerosis. Those are multiple causes of spasticity. So, what are the drugs that are used? As I said, most of them are centrally acting, or rather 3 in fact are the ones that are commonly used and that I am going to be discussing, and 2 of them are peripherally acting. So, the ones that are peripherally acting are dantrolene and botulinum toxin. Botulinum toxin would already have been actually discussed in autonomic pharmacology as well as physiology, but if we have time, we will look at it a little bit today also. What about the centrally acting? Any idea of centrally acting skeletal muscle relaxants? Sedative hypnotics is over for you? Benzodiazepines? Nahi? Okay. Anyway. So, any idea about centrally acting skeletal muscle relaxants? एक clue तो वैसे मैंने दे ही दिया. One is the benzodiazepines and especially diazepam. Sometimes clonazepam, midazolam may also be used, but mostly diazepam because we have the greatest experience with diazepam. There are other benzodiazepines which would also cause skeletal muscle relaxation, but we have experience with diazepam in skeletal muscle relaxation. So, this is the one that is recommended, and you all know diazepam is a GABA A facilitator, not an agonist. I am sure, you said you haven't covered benzodiazepines. So, why do we say it's a facilitator? Anyway, we will discuss that when we come to it. Then we have baclofen, which is a GABA B agonist, okay, and we have tizanidine, which is a central alpha 2 agonist. So, coming to these one by one, benzodiazepines, that is diazepam. So, as I said, it is a GABA A facilitator. That means it does not bind to the GABA site at the GABA A receptor. It binds to another site and facilitates the binding receptor. So that's why we say it's a facilitator. Okay, it's not an agonist. It doesn't bind at the same site, as you can see from this. So this is the diagram of a GABA, receptor, which is, as you can see, a ligand gated ion channel like the nicotinic receptor. But here the main ion that crosses it is, when it's open, is chloride. Okay, and GABA, I'm sure you know, is a excitatory or an inhibitory? It's a inhibitory neurotransmitter. So it is increasing the action of a inhibitory neurotransmitter. And where do you think? Both spinal and supraspinal level. And so this, I'm sure you are familiar with this, orientation of upper motor neuron, okay, synapting with an inhibitory interneuron in the spinal cord. You have the motor efferent acting at the skeletal muscle. And let's look at the bigger picture. क्या हुआ? कुछ हर्षित कुछ हो रहा है वहाँ? कुछ problem? Right? Okay. So this is the bigger picture here. If you can see, so this is again the smaller, part is what I had shown in the previous slide. So you have the corticospinal pathway neuron, that is your upper motor neuron, okay, which is now connecting with the motor neuron in the spinal cord, and then you have the efferent going to the, that is your motor neuron going to the muscles, okay, or the muscular fiber. Okay, so where do you see the GABA A receptor here? Here. Okay, it stops working. Anyway, if you can see here, this is the GABA A receptor. And what is happening is, this is the inhibitory neuron. So from the inhibitory interneuron, GABA, which is inhibitory neurotransmitter, is released, which acts on the motor neuron and inhibits it, and that's why we have the release. And this actually balances the muscle contraction in a normal individual also. So that's why we don't have spasticity, we don't have our muscles contracting all the time. And in a patient with spasticity, that is what benzodiazepines are going to do. They are going to further facilitate the action of GABA, so it can act here and inhibit the spasticity. Yes, there. Okay, so that is the mechanism of action, simple mechanism of action of benzodiazepines, which is the mechanism of action of a lot of their actions in the CNS. Okay. Now, baclofen. Achha, what about the uses? Did I skip a slide? क्या हो जाता है थोड़ी देर बाद? Where is the connector? Anyway, let's not waste time. So, diazepam can be used, and this includes not only as a neuromuscular blocker, for other indications also. It can be used orally, it can be used intravenously. It can also be given by rectal administrations, for example, in a child or in an unconscious patient if you don't have IV access. Okay, and the main use is in, actually diazepam is useful for almost all conditions with spasticity. Okay, it can reduce the spasticity, it can reduce the pain. Only problem is, being a benzodiazepine, it will cause sedation, it has abuse liability, it can cause tolerance and dependence. Okay. So that is the main problem. Otherwise, it would be useful in most of the conditions with spasticity. Now coming to baclofen. So baclofen, as I mentioned already, it is a GABA B agonist. So first of all, it is not GABA A, it is GABA B. The other difference is, it's not a facilitator, it is an agonist, unlike diazepam, which is a facilitator. So it actually acts at the GABA B as an agonist, where it causes hyperpolarization, okay, which reduces. So depolarization increases calcium influx, okay, through the synapse or the neuron, and it causes increased release of neurotransmitters, while hyperpolarization is going to decrease the calcium influx, and there is going to be a decreased release of the neurotransmitter that would help to reduce the spasticity. Okay, and it may also reduce pain. Now, the reduction in pain due to baclofen may be because of reduction of release of substance P, or what we now call neurokinin 1, which I hope you know from your physiology that it's a mediator of pain. So, this is the diagram. Now, another thing to be noted is GABA B is what kind of a receptor? Is this is ion channel? No, and actually these are two receptors, so it's a heterodimer. Okay, so GABA B actually for activation or for action, the receptor forms heterodimer. So there is this receptor and there is this. Both are GABA B receptors. Don't get confused by R1, R2. R1 is one receptor and R2 is the other receptor. Okay, and AB are actually like asterisks. They are references. So don't get confused by that. So this is a GABA B receptor and it is two receptors together. It's a heterodimer. Two types. So there are two types of these receptors which have to form a dimer to act. Okay, and what kind of a receptor is this? If you see, there are 1, 2, 3, 4, 5, 6, 7 transmembrane helices. Okay, and if you see here, you have G, I, O, you have an alpha, you can see probably not very clearly, but there is an alpha, beta, gamma subunit. So what kind of a receptor is this? It's a G protein coupled receptor. So GABA A is an ion channel receptor, while GABA B is a G protein coupled receptor. First of all, you should remember that. Okay, and so what does this do? Stimulation of the receptor opens the outward potassium channel. Okay, so potassium goes out, so that is the reason for the hyperpolarization, and as you can see, it also directly inhibits the calcium channel. So there is, and this is an invert calcium channel, if you can appreciate that arrow. Okay, so there is reduced intracellular calcium and there is hyperpolarization, which is a reason for the reduced secretion of the excitatory neurotransmitters by baclofen. So that was the mechanism of action of baclofen at the receptor level, and here you can see the, in the same, I am purposely using the same diagram if you can figure out. So this was the corticospinal pathway neuron, okay, where you have GABA B. So it is there both prejunctionally as well as you have it on the motor neuron, and baclofen will inhibit both of them. Okay, so prejunctionally it will reduce the release of neurotransmitters. So that is the effect of baclofen. Use now, baclofen is used both orally and in patients with severe spasticity associated with pain, who are not getting relief from any other drug. Then baclofen intrathecally is also given. So you place a catheter, in the spine, and it is left there for months. The only danger is that there can be malfunction of the catheter and cause problems, but otherwise this does provide relief for patients who are not getting relief from any other muscle relaxant. So it is even used intrathecally, but the more common way, of course, to use it would be to use it orally. So baclofen is used for spasticity, conditions associated with spasticity, especially spinal cord injury or other spinal cord lesions. Okay, or MS, that is multiple sclerosis, or ALS, that is your amyotrophic lateral sclerosis. It's not very useful in stroke, and definitely now, like all anti-spasticity drugs, it's not useful in Parkinson's. Okay, it has also been tried. Okay, it's not established therapy, but tried for intractable low backache. So low backache, that's not you are not getting relief from anything else. Baclofen has been tried. It also decreases craving for alcohol, nicotine, cocaine. So it's been used as in the de-addiction program for these drugs, and it may also be used as a drug to prevent migraine. Again, if nothing else is working. So those are the other potential uses of baclofen. Adverse effects of baclofen, similar to diazepam, it does cause sedation, but the sedation is less than diazepam. And it does cause weakness, but the weakness is less than dantrolene. So dantrolene causes the most weakness, diazepam also causes weakness, okay, but the baclofen causes less weakness than dantrolene. Then it can also cause hypotonia, especially in overdose. So you have too much of inhibition of the muscle. So you could have hypotonia, you can have ataxia. At the central level, you can have confusion, you can have fatigue, nausea, and also very important to remember, it can reduce seizure threshold. So in a patient of epilepsy, we avoid to use baclofen because it can precipitate a seizure. Also, it is eliminated by the kidneys. So in a patient with renal failure, you again have to be careful because it can accumulate. Another thing to remember about baclofen is that, in fact, even diazepam, which is a CNS drug, do not stop them suddenly. Okay, if you stop them suddenly, in case of baclofen, there can be seizure, and in case of both drugs, there can be increased spasticity. So we always taper these drugs before, that is, reduce their doses gradually before stopping them. Then next, the third centrally acting drug is tizanidine. Now, tizanidine, like hypertension is of course over. Remember any alpha 2 agonist, centrally acting alpha 2 agonist for hypertension? Clonidine. Okay, so tizanidine is also centrally acting alpha 2 agonist, but unlike clonidine, it does not decrease the blood pressure as much. In fact, it has some 1/100th potency at decreasing blood pressure. That is, it does not act at peripheral alpha 2 receptors or even at the central alpha 2 receptors, which are concerned with decreasing sympathetic tone as much as clonidine. Okay, so therefore, it has been used as a centrally acting muscle relaxant. So what does this do? So this at the central level, okay, both at the level of the spinal interneurons as well as the cerebrospinal pathways, it reduces. So alpha 2 is mostly present prejunctionally. So it acts at the alpha 2 receptor. Here the alpha 2 receptors reduce by being stimulated, okay, inhibit the release of neurotransmitters, and especially the excitatory neurotransmitters, that is glutamate and aspartate, okay, which is so reduction in these excitatory neurotransmitters at the in the motor pathway is going to reduce the muscle spasticity. So that is what tizanidine does. So again, coming back to the same diagram, and this is where you can see the prejunctional alpha 2 receptors, which again, of course, like all adrenergic receptors, alpha receptors are G protein coupled receptors. Okay, so tizanidine is going to act here and inhibit it. Oh, sorry. So tizanidine is going to act as an agonist, but agonism then leads to inhibition of release of. So this is glutamate, which is one of the excitatory neurotransmitters from the corticospinal pathway, neuron, which is then going to act at the. So this is the glutamate receptor in the motor neuron. So this is going to reduce. So glutamate is an excitatory neurotransmitter, but this is going to be inhibited. Okay, so there is going to be reduced spasticity. So tizanidine is only used orally, unlike the other two drugs that we discussed, and it's used for spasticity due to various reasons, and it's also been tried for migraine. So many of these drugs, as you can see, have been tried for chronic migraine, okay, and it causes less muscle weakness than these previous two drugs, but it does cause drowsiness, dizziness, dry mouth, because probably of a related anticholinergic effect. Okay, and as we will see, there are a lot of other drugs, especially available in countries like India, which are used as skeletal muscle relaxants, which are available as combinations with paracetamol. Can anybody name any skeletal muscle relaxant? I am very sure many of you have taken skeletal muscle relaxant when you have maybe, especially if, how many of you play some sport? गेम्स, कोई फुटबॉल, बैडमिंटन, कोई क्रिकेट खेलता है? कोई कभी लिया है मसल? नहीं लिया है रिलैक्सेंट तो अच्छी बात है, but many times they are used unnecessarily along with paracetamol. That anyway I'll come to the end. So what I'm trying to tell is, even all of them have anticholinergic effect, and all of them are liable to cause sedation. Now coming back to tizanidine, so as I said, it has all these problems mostly because of the anticholinergic effect, but it can also cause hypotension as well as asthenia. But if you stop it suddenly, then it can cause a rebound hypertension, which is very much like what happens with clonidine. Clonidine, if you remember, the only reason clonidine is not used widely is because of the problem of rebound hypertension on stopping it. So same thing happens with tizanidine. If you stop it suddenly, there can be rebound hypertension, though it itself causes hypotension only in higher doses, okay, but when you stop it suddenly, it can cause hypertension similar to clonidine. And so you have to be very careful in a patient who is already on hypertensive therapy for both reasons. You do not want hypotension, or neither do you want hypertension in them. Tizanidine has also been associated with hepatotoxicity. So you might want to, if you are giving it for a long term, you might want to monitor liver enzymes. Now lastly, so those were the centrally acting muscle relaxants. So any questions, or do you want 1 minute break before we go on to the last 15 minutes, the peripherally acting only 2 drugs? So okay, you can take 1 minute break. Now वो बॉटल जो पास हो रही थी अभी हो सकती है, जिसको पानी पीना है, उठना है, मतलब यहीं पे उठ के बैठ जाओ, wake up those who were sleeping, though I hope nobody was sleeping. या किसी को कोई क्वेश्चन पूछना है? कुछ पूछना है? थोड़ा चेहरा ही क्वेश्चन मार्क है. So many of you, yeah, I know I am being recorded, but I don't mind saying that. Many of you do sit here and I'm saying that because that has just been kind of, I've just gone through that, meaning, yahan itna disinterested, many of you are sitting. Okay, I'll try not to look at certain people. फिर जब attendance नहीं है या marks नहीं है, then you come with such a sorry face, and then also you don't come in time, you just come now. अभी आपके junior batch का, ये supplementary batch का परसों तक हमको देना है eligibility. Somebody with say 56%, 60% attendance is then coming to me कि मैडम कुछ कर दो. अब मैडम क्या कर दे? अब कहाँ से attendance? So अब आपकी and classes, and we have a very transparent system of attendance. We put 1, 2, 3, 4, 5, 6, and which actually is very convenient for having the total attendance. We don't put P. If you have you people see, we put 1, 2, 3, 4, 5, 6. Okay, so there is no option of doing anything, and anyway, why would we do anything? So अगर आपको really pass, मतलब कोई भी subject करना है, पास करना है, तो अटेंडेंस ज़रूरी है. 75% अटेंडेंस ज़रूरी है तो है. सो अब हम क्या करें, है ना? और फिर बाद में आप ही लोग अभी तो ऐसे बैठे हो, कुंड केयरलेस, बट बाद में फिर ऐसे आते हो कि मैडम कुछ कर दो. सो अभी ही थोड़ा अटेंशन दे दो, इंटरेस्ट ले लो, क्लियर कर लो, है ना? चलो, ओके. So 1 minute, I'm sorry that break was not a very entertaining break, but yeah, let's come back to the topic and finish it. So we have only 2 peripherally acting muscle relaxants, that is dantrolene and botulinum. Both of them a little bit you already by now know. Dantrolene, so where does it act? It acts at the ryanodine R1 receptor. And where is this receptor? This receptor is at the sarcoplasmic reticulum, as we had seen yesterday. And what happens if there is a genetic problem with this receptor? What can happen if there is a genetic problem with this receptor and we use general anesthesia? Yes, there can be malignant हाइपरटेंशन. क्या नाम है बेटा आपका? हाँ हाँ प्रतीक. हाँ प्रतीक, क्या प्रॉब्लम है? आप क्यों सो रहे हो क्लास में? नहीं, सॉरी का वही तो ना, फिर बाद में आप बोलोगे नहीं आता. एनीवे, सो द प्रॉब्लम इज दैट so certain patients who have a problem with this receptor, when they are exposed to drugs like general anesthetics and neuromuscular blockers, there is a very large or massive release of calcium, okay, which leads to muscle contraction, and that is why dantrolene is active there, because dantrolene inhibits this ryanodine receptor. So, normally of course, also we need this ryanodine receptor, because calcium which comes from outside is not enough to sustain the muscle contraction. It is just to trigger calcium, then it causes release of calcium from the sarcoplasmic reticulum, and then there is excitation and contraction of the muscles. So, if this is inhibited, then there is uncoupling of excitation and contraction. That means, even though the cell is excited, but there cannot be enough release of calcium, and then there is no contraction. So, that is what dantrolene does. Now, the question is, why not the cardiac muscles and the smooth muscles? Why doesn't dantrolene inhibit contraction of the cardiac as well as the smooth muscles if it's decreasing the release of calcium from the sarcoplasmic reticulum?
Because such muscles, calcium ions come mainly from extracellular rather than the sarcoplasmic.
Yes, it comes mainly from the
Extracellular matrix.
Okay, so one is they are less dependent on the sarcoplasmic reticulum calcium. The other reason is even the calcium which needs to come out from the sarcoplasmic reticulum comes from a different receptor. So, they have RYR2, they have ryanodine 2 receptor in the sarcoplasmic reticulum. So, the other muscles are not much affected by dantrolene. The route of administration of dantrolene may be oral or may be IV. Definitely when we are using it for malignant hypothermia, we are going to use it IV, because it is an acute life threatening condition where we want fast action. So, there we will use it IV, but it can also sometimes be used orally, especially if we are using it for spasticity in a bedridden patient, then we can use it orally. So, the uses of dantrolene is for spasticity in a bedridden patient, for malignant hypothermia. Sometimes it has been tried, though it is probably not very effective for neurolep malignant syndrome. Now, antipsychotics I am sure are not done, if sedative hypnotics are not done. Anyway, so when you are taught antipsychotics, or probably already in physiology, have you heard of this neurolep malignant syndrome or neuroleptic malignant syndrome? Okay, so that is an adverse effect of antipsychotics. Antipsychotics actually act by, most of them, especially the older ones or the typical antipsychotics, act by antagonizing D2 receptor, that is a D2 dopamine receptor. And the D2 antagonism can lead to what disorder, which is a common adverse effect of typical antipsychotics. This is physiology. Dopamine or a deficiency of dopamine can cause what disorder? Parkinson's, right? So, some patients are very sensitive to this dopamine antagonism of antipsychotics. So, they have this severe, it is nothing malignant, neurolep malignant syndrome is nothing but a severe kind of Parkinsonism, where there is acute muscle. So, here there is muscle rigidity, okay, not spasticity. Here this is muscle rigidity because of an acute Parkinson like syndrome, and there will be muscle rigidity, and if the patient is not sweating enough, there can be increased temperature because of the muscle rigidity, and there is usually autonomic instability in neurolep malignant syndrome. So, and that is why, because it is not the spasticity, it is the rigidity that is the main factor. So, dantrolene is not very effective, but because there is nothing else also which is very effective for these patients. So, dantrolene is sometimes tried for them. Adverse effects of dantrolene include the weakness, drowsiness, lethargy, nausea, as well as diarrhea, and on chronic use it can also cause hepatotoxicity, which for some reason is more common. There are reports of more adverse effects of this hepatotoxicity in women, especially women over 35 years. Okay, it is also more common in the elderly, probably because already compromised liver or reduced liver function, and of course, understandably, it will be more in patients who are already taking a drug for which has a hepatotoxic potential. Say many of the antitubercular drugs have hepatotoxicity. So, if a patient is taking ATT as well as a patient is taking dantrolene, then more chances of hepatotoxicity. Those are easy to understand. Why women more than 35 years? We don't know, but the ADR reports say that it's the women more than 35 years have more incidence of toxicity with dantrolene. Lastly, we have the botulinum toxin that I am sure you already know from ANS pharmacology as well as from your physiology. Okay, so this is a toxin from the bacterium Clostridium botulinum, obviously you know that. Okay, and what does it do? It inhibits the release of acetylcholine, you know, from at the neuromuscular junction or any of the parasympathetic, you know, neurons. And how does it do that? I am not sure if you are able to read that, but anyway, first of all, you should know it inhibits the release because it inhibits the vesicular function here. The docking of the I'm sure you know that from probably physiology that neurotransmitter release, mostly the neurotransmitters are stored in these vesicles. When there is stimulation leading to increased calcium inside, the vesicle is going to first dock at the outer membrane, and then the vesicle is going to open and the neurotransmitter is going to be released. Now, this process involves certain proteins, okay, which is actually a complex of proteins called SNARE, okay, which includes synaptobrevin, it includes a protein called SNAP as well as proteins called syntaxin, okay, and botulinum toxin, actually the toxin itself is a big chain and it divides into a light and a heavy chain. So, both the light and the heavy chains can be part of the mechanism. The light chain binds to, here if you can appreciate, blue is synaptobrevin, but that is okay. Even if you don't, botulinum toxin is not such an important drug that even if you don't know the exact nitty-gritty of the action, in the end you should know that it inhibits release of acetylcholine, okay, by inhibiting vesicular function. But if you can appreciate the colors, so it binds to both synaptobrevin and SNAP particularly, but also syntaxin, okay, the light chain. The heavy chain may directly antagonize, so this is the botulinum toxin, okay, so it directly antagonizes the botulinum toxin by binding to it, and so both combined, the end result is that there is a reduction in release of acetylcholine, okay, at the neuromuscular junction. So, the uses, probably the use that would have been discussed when we were doing ANS was it's used in strabismus, blepharospasm, used for facial spasm, and probably the most common use is as a treatment for wrinkles especially by celebrities and people in the business of fashion, okay. They use local injections of botulinum for wrinkles, as well as it has now also been used for generalized spasticity, that is, you can inject it in the various limbs, you can give local injections in the limbs, and this also helps again in a patient where nothing else is helping. One injection can help for about 3 months. Okay, and in any case, it's better not to repeat before 3 months because chances of a hypersensitivity reaction also increase if you give it too frequently. So, usually if you use it for any chronic condition, we repeat injections at 3 months, or even if you are using it for cosmetic purposes, you should not repeat before 3 months. Okay, so that is what nowadays it's also been actually approved for incontinence due to an overactive bladder by reducing the bladder contractions, as well as for chronic migraine. So, another spasmolytic which is used for migraine. Okay, and as I have already said, it can be injected into a specific muscle group. Effect lasts for 3-4 months, but don't repeat before 3 months. Adverse effects of botulinum toxin, it has been sometimes due to excessive weakness, it has been shown to cause muscle paralysis, which is especially dangerous if there is respiratory muscle paralysis, okay, and probably because of the respiratory muscle weakness, there is an increased risk of or rate of respiratory tract infections have been seen in a patient on chronic botulinum toxin, and it can itself cause urinary incontinence. So, we are using it for urinary incontinence, but it can also cause urinary incontinence. And why is that? Why do you think is that? So, urinary incontinence is not always due to an overactive bladder, you know. Bladder is overactive, you can have urinary continence. Bladder is not, that is the sphincter is not contracting, you can have urinary incontinence. So, probably here adverse effect urinary incontinence is probably because of probably because of reduced contraction of the sphincter of the bladder. Okay, and as I've already mentioned, hypersensitivity with nowadays the preparations is not so common, but still to avoid hypersensitivity, it's better not to repeat a botulinum toxin more frequently than every 3 months. Okay, then there are some other drugs, don't worry, I'm not going to discuss them, you will find them in your books, but even if you don't know anything about them, gabapentin, pregabalin, anyway you will come across when you do antiepileptics. They are used more commonly for various other reasons, including neuralgias and low backache rather than for epilepsy. Then you have progabaid, glycine, you have hydroselamide, riluzole. If you're interested, or you can read, but these are just some drugs which even if you don't know, it's okay. And lastly, as I said, there are a lot of what we call antispasmodics, so drugs which are useful only for localized spasms. They are not helpful for generalized or severe spasticity, and these you will find fluoroxazone and methocarbamol combinations with paracetamol, brufen, diclofenac, that is NSAIDs very commonly. Okay, but be careful, only use them or prescribe them if needed. Okay, every time you have some muscle injury, skeletal muscle injury, you do not need a skeletal muscle blocker, you just need an anti-inflammatory and an analgesic. Okay, but very often they are overused, misused, especially in India. Okay, so, you have these fixed dose combinations. So, rather than when to use, I am just telling you to not to use them. Usually they are not required, maybe by athletes sometimes they are required, but otherwise they are usually not required. And all of them have anticholinergic, whether or not the drug information says it. If you really go deep into the drug information, you will find all of them have anticholinergic effect, all of them have sedation. Okay. So, carisoprodol actually is metabolized to meprobamate, which is a sedative, which was earlier used as a sedative, and carisoprodol also was earlier used as a sedative. Anyway, okay, it's 3 o'clock, so we'll stop it, and won't summarize. I think I'll stop because of I had a few summary slides, but I don't think it's required. I think I've repeated things enough number of times. So, can somebody, Chirag, can you take the attendance? I don't know what I'm supposed to do with this, and how are we supposed to turn it off? I don't know. Just keeping it inside.
1, 2, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19,